member of staff settled in, doing her induction, and you may have heard that the UK, well, not the UK, England more specifically, have gone back into a second lockdown as of last week. So despite that, we've been very busy. We had a lot of clients booking in prior to the lockdown for obvious reasons, so they can get their ears treated in advance. So I do apologise. Hopefully, I'm still working quite closely alongside our new member of staff, just getting them all settled in, but hopefully I'll have a bit more time in the next few weeks to catch up and upload a lot more videos. So we have a client here who attended last week, bilateral occluding earwax. The ear canals, or entrances at least, in both eyes were very narrow and very slit. So getting access into the ear was a bit difficult. This is the patient's left ear. You can see that we're just at the entrance, and you know we're at the entrance because you can see all the hairs, all the cilia. The hair follicles in the ear canal are in the outer third of the ear canal, the cartilaginous portion of the ear canal. And with this patient, we have to kind of almost stretch your ear canal open, almost like a crowbar. So you'll see me lifting the ear canal entrance up there with the Zollner suction probe, which widens the ear canal and then allows me to insert the eye clear scope. The wax that's very lateral, so near the entrance, it's quite glutinous, quite sticky. So we're just trying to, and it's a few skin adhesions there, so we've just got a suction grip and I'm just wriggling it through because the entrance is quite narrow. When you're removing wax from a narrow ear canal entrance, you do have to wriggle quite a lot really to tease that and manipulate that wax out. So it's just on its way out there. A little piece got cut off from this larger piece because of the narrow entrance. There we are, just tugging this out. With this type of wax as well, it can quite often block the suction probe because it is quite sticky, so there's a big piece of wax there. So she's got some sticky wax anteriorly, so on the left hand side, the front of the ear canal near the entrance, but we're just going to go for this very deep impacted wax that's very medial, so closer to the eardrum. Well, I've gone back for the sticky wax anteriorly near the entrance, possibly just to clear the way actually for this bigger piece to come out. So you can see this wax has quite obviously been in the ear canal a lot longer than the earlier wax that I removed. You can tell that by the colour. This wax is a lot darker, it's oxidised, so the longer the earwax is in the ear canal, it oxidises. Always compare it to an apple or an avocado. As you cut through an apple or an avocado, it turns black after a few minutes, and that's because the oxygen reacts and it oxidises it and it changes colour, similar with earwax. So I brought this medial large lump of wax near the entrance, and it is a large piece of wax, and as I mentioned, the client's ear canal entrance is a bit narrow and slit, so we're stuck at the entrance now, but there's a bit of a gap there, so I think I'm just initially using an ear hook to try to get in behind the wax. I think the ear hook just sliced through it, so I'm going to then use the Jobson horn. There we are, just getting in behind the wax, pulling this through. It's a very large piece of wax, and I think I'm going to get all of it in one large piece. So there's the patient's tympanic membrane, slightly opaque, slightly retracted to the eardrum, is slightly pulled inwards, buckled into the middle ear, and that's typically due to eustachian tube dysfunction. You can compare it to when you're on an aircraft and an aeroplane. As you descend on the aeroplane, the air pressure in the cabin is a lot greater than the pressure behind your eardrum, so the eardrum gets sucked in and you feel blocked, and you normally close your mouth, pinch your nose and blow. You force air up your nostrils, up the eustachian tube, which is a narrow orifice that connects the back of the eardrum, the middle ear, to the back of the nose. So we force air up the eustachian tube to pop the eardrum back out. So the eustachian tube is the pressure equalizer in the ear, and it's also a drain pipe, so any fluid that accumulates, so any effusion, that's what we call fluid, any middle ear effusion that accumulates, it can drain away if that eustachian tube is blocked, and also not only does the eardrum get sucked in, so there's no air there, so it's a vacuum effect, but fluid starts to accumulate, and you can develop glue ear. So just on the right side, you can see again how narrow and slit the entrance is. So just gone in with the Zollner suction probe initially. Again, the wax is quite glutinous, but you can see it. Just like the first ear, the left ear, you know we're at the entrance because you can see all the cilia, all the hairs at the entrance, and it's a very tight squeeze there, just even to get access. So I've just gone in with the eye clear scope, and I'm kind of stretching the ear to the left and widening it. I'm using the eye clear scope as a crowbar almost to widen this ear so we can get this wax out. So I've stretched the ear, and this wax does want to come out, but it's just getting trapped still. I think I'm going to use the Jobson horn. Don't worry guys, that Jobson horn was used in the left ear first, so it's not between patients, between ears. We're okay to use the same instruments between the patient's ears, just as long as they don't have an infection in one ear, or the first ear. So there was an opening there, just getting the Jobson horn in behind the wax. So this wax is still a bit lateral. Again, just stretching the ear open, just slowly inserting the Jobson horn into the opening at the roof of the ear canal and bringing it forward, gently scooping the wax out. We've got to be very careful we don't make contact with the floor of the ear canal, the base of the ear canal, because that can be a bit uncomfortable, and it can elicit the gag reflex. You've got the Arnold's nerve at the base of the ear canal, and if you stimulate that, people tend to cough. When we're working on the outer part of the ear canal, though, we can put some pressure on the ear canal, not too much, but just because it's cartilage, so the patient, it's almost like a buffer effect. Cartilage is quite malleable. If you wriggle the outside part of your ear, it's not uncomfortable, but the inner 2/3 of the ear canal, it's a thin layer of skin, 0.1 millimeters thick, just coating bone, whereas the outer third, you've got a thicker layer of skin, so about 1 millimeter, 10 times thicker. You've got some fatty tissue as well, so it's like a buffer, and then you've got cartilage. So and there we are, just having a peek. There's typically a blind spot when you enter the ear canal to the rear. You can see, just see a bit of wax there, and that's what's great about the endoscope. We can really visualize all the kind of hidden areas of the ear. You can see the eardrum's intact, slightly opaque, just like the left side. Good light reflex, and the patient's symptoms were completely alleviated. So there we are, and there's all the remnants. You can also see my clear scope, the eye clear scope device. Well, that's the endoscope itself. You can see all the remnants. Thank you for tuning into that video, guys. If you're watching on YouTube for the first time, feel free to subscribe, select the bell icon so you'll get notified as and when I upload new videos. Similarly on Facebook, feel free to like, share the page, comment on the video. I'm hoping